Okay, so let's start respiratory physiology. And one of the main things over here is the idea is to get oxygen into your tissues somehow, and then to take the carbon dioxide which your tissues produce and, get it out of the body. So that's what this picture is really showing you. So you intake oxygen into the lungs, you inspire oxygen, and then you expire carbon dioxide, and then we'll see how this actually is transported to the tissues. Now, as a review, let's look at, just go over a little bit of the anatomy and also try and kind of weave the physiology with it. So let's look at this video.
In order to stay alive, the body has to breathe air. We breathe in oxygen and we breathe out carbon dioxide. This process is known as respiration. Breathing happens automatically. Every day, the body breathes about 1,000 times. By the time we reach 70 years old, that's about 600 million breaths. Breathing occurs because system. The nose, throat, voice box, windpipe, and lungs. At the top of the respiratory system, the nostrils bring air into the nose, where it's filtered, warmed, and moistened. Tiny hairs called cilia protect the nasal passageways and other parts of the respiratory tract and filter out dust and other particles that enter the nose through the breathed air. Air to be breathed, the nose and the mouth meet up at the pharynx, which is located at the back of the throat. The pharynx carries both food and air and is used for digestion and respiration. One path is for food. This is called the esophagus, which leads on to the stomach. The other side is for air. It's called the trachea. A small flap of tissue, called the epiglottis, covers the air-only passage when we swallow. This stops food and liquid from going into the lungs. The larynx, or voice box, is located at the top of the trachea, the air-only pipe. This is where our vocal cords are. The trachea, or windpipe, which is a 2 to 3 centimetre tube, then extends downwards from the bottom of the larynx for about 12 centimetres. The walls of the windpipe are made strong by stiff rings of cartilage that keep it open. The trachea is also lined with tiny hairs. They sweep foreign particles and fluids out of the airway, keeping them from entering the lungs. The windpipe divides into 2 branches, and each one of these enters one of the 2 lungs of the body. Each branch resembles the limbs of a tree, dividing into smaller, finer branches called bronchioles. The bronchioles end in tiny air sacs called alveoli, which look a bit like grapes. These structures enable fresh air to get to the air sacs, which are surrounded by tiny blood vessels, or capillaries. The oxygen passes through these air sacs and travels through the capillary walls into the bloodstream. At the same time, carbon dioxide transfers from the bloodstream into the air sacs, where it gets breathed out of the body. When we exercise, the body needs more oxygen to feed the muscles as they work harder. The body responds by breathing more deeply. As the cells and muscles use up more oxygen, the lungs have to work harder to keep supply. The respiratory system then speeds up to supply the body with much needed oxygen and also get rid of the waste in the system. Over time, exercising also helps our chest cavity to get bigger, which enables the body to increase the amount of air it takes in. More capillaries form around the air sacs, so the body gets better at swapping oxygen and carbon dioxide gases. We can see how the body's respiratory system helps the body to move about, and is influenced by regular and ongoing physical activity as well.
So that was a quick review on how, you could see how oxygen and carbon dioxide moved out in the alveoli. Okay. So here, when we look at the physiology of respiration, we are going to see this under 4 main headings. One is ventilation, which is the mechanics of breathing. What makes you inspire and what makes you expire. So you have inspiration and expiration, which are under mechanics of breathing. Then there is transport of gases, and this transport occurs one at the lungs, which is called external respiration, where you saw from that video and right at the first slide where carbon dioxide enters the lungs and oxygen from the lungs enters into the blood vessels. This is then transported to the tissues where the opposite happens. So this oxygen then now goes to the tissues, and the tissues are metabolizing and producing carbon dioxide, and that carbon dioxide is transported by means of veins, and then it goes into the heart, and then the whole cardiac cycle starts. Okay, so that's known as internal respiration, which occurs at the tissues. So this is the gas exchange. The third part is where we see how these gases which are to be exchanged, how these gases are actually transported in blood. And then finally, the control of respiration. So let's look at this quickly, the physiology of respiration.
Ventilation is the first stage of the respiratory cycle, followed by external respiration, internal transport, and internal respiration. Ventilation has two components, inspiration and expiration, the transportation of air in and out of the lungs. Air movement is driven by changes in the pressure within the thoracic cavity. During inspiration, pressure inside the cavity decreases below that of the outside air, causing air to flow into the lungs and expand the size of the thoracic cage.
So let's look now first at the mechanics of breathing. So we have certain pressures that we have to be, cognizant of. The first one is the intrapulmonary pressure. As the name suggests, this is the pressure in the lungs. So intrapulmonary pressure is the pressure in the lungs. And this pressure, even though it fluctuates, when you're inspiring and when you're expiring, and you'll see how the pressure goes down and the pressure goes up at certain times. But the aim is finally to attain the same as atmospheric pressure so that the gradient remains flat, okay? Because there's a gradient, air flows in or air flows out, and then when the intrapulmonary pressure reaches the atmospheric pressure, it stops. So that's what the aim of intrapulmonary pressure is. And then we have a pressure which is present inside the pleural cavity, which is known as intrapleural pressure. This has to be negative. It has to be less than the intrapulmonary pressure, because if it was positive, what would happen? It would compress the lungs and the lungs would collapse, right? So what is that condition called when the lungs collapse? Atelectasis. Remember when you had something called pneumothorax, where there was air inside the pleural cavity, then pressure becomes positive because now it's more than the intrapulmonary, so it will push against the lungs and the lungs will collapse. So you want the intrapleural pressure to always be negative. Now in the lungs and the pleura, now there are two opposing forces. One is that the lungs have a lot of elastic tissue. And they have a tendency, because of the elastic tissue, what happens to elastic tissue? It has a tendency, like a rubber band, it's tendency to recoil. So there is a tendency for the lungs to kind of recoil. So if you look at the lungs, if I just draw one like this, there's a tendency for the lungs to kind of recoil and come towards the center or towards the hilum. And the second is that if you remember in the alveoli, because the fluid comes down right from the top, the fluid molecules which are present here, the water molecules at the gas fluid junction, they tend to want to stick to each other. So there is a surface tension which is present. So this inherent tendency of the lung, because of its elastic tissue, to collapse towards the center, plus the presence of surface tension to make the alveolar wall stick to each other, that will have a tendency to make the lungs collapse. But opposing these two is that we have surfactant, which you remember was produced by the type 2 cells. And what surfactant does is decreases the surface tension, so it makes the alveoli expand. So it opposes that surface tension. And the second is that the chest wall is also elastic, and the chest wall moves outwards. So one force tries to push the lungs towards the center, the other one is trying to pull the lungs outside and make the alveoli inflate. So these forces kind of balance each other out, and what happens is, because the chest wall is lined by parietal pleura and the lungs are lined by visceral pleura, if you remember the pleural cavity like this, right, and this is the lung here. So the parietal pleura lines the chest wall, which is trying to go out. The visceral pleura lines the lungs which are trying to go in, and the forces negate each other. And because of this little fluid which is present, what happens is these two layers tend to stick to each other. Very similar to like two glass slides. If you put a bit of water between them, they can be moved against each other, but you cannot pull them apart. It's very difficult to pull them apart, okay? So the two layers stick to each other and they prevent the collapse of the lungs, okay? So that's the net result of what happens. Now, look at this question. And here we have Adam was involved in a gang fight and he's stabbed on the right side of his chest wall. And he has to be rushed to the ER because his breathing is severely compromised. So why do you think that is so? What is the primary cause? Okay, I need one more response. Very good. Yes, air has entered his pleural cavity, so the pressure has become positive and that's why the lung has collapsed. So let's look at this pulmonary ventilation in a little bit more detail, and this mechanics of breathing. So it consists of two processes. One is called inspiration, the other one is called expiration. Inspiration is an active process where muscles are used. And this increases the whole thoracic cage diameter. So this, which increases the diameter of the thoracic cage. And because the diameter of the thoracic cage is increased, you will find, since remember the parietal and visceral pleura stick to each other, so the lungs will also, the lung volumes also will increase. So the diameter first of the thoracic cage is increased both in a vertical diameter. So if I draw the thoracic cage for you like this, it's increased vertically, it's increased transversely, and it is increased front to back, like this, from the sternum to the vertebral column, front to back, which is the anteroposterior diameter. So it's increased in all three ways. And the two inspiratory muscles, which are used at rest, so when you're sitting in class and breathing, the two inspiratory muscles are the diaphragm and the external intercostal muscles. The diaphragm and the external intercostal muscles. So this is at rest. Either one of them at rest can actually maintain ventilation, maintain inspiration. So let's say if the diaphragm was paralyzed, the external intercostal muscle is adequate enough to maintain respiration at rest. Or if the external intercostals were paralyzed, the diaphragm is adequate enough. In fact, actually the diaphragm does 75% of the work. So even if the 75% is gone and the external intercostals are remaining, they can still carry out their work. But if something happens where you have to breathe more deeply, then there would be a problem. So that is forced inspiration, where you use a lot more muscles. So not only do you use the diaphragm and external intercostals during forced inspiration, you also use this muscle called sternocleidomastoid, which is attached to the sternum and the clavicle and goes up to the mastoid process. You use these little scalene muscles which are present in the neck. And this big muscle which is present in the pectoral region on the chest wall, the pectoralis major. Pectoralis minor also helps a little, but these are the three main muscles which help. Now, in order to understand inspiration and why air moves in before you even think of the vertical, transverse and anteroposterior diameters, what you need to understand is a particular law which is known as Boyle's law, which states that pressure, P stands for pressure, is inversely proportional to volume. That means that, so if you look at it this way, P is 1 over V. So automatically, if your volume will decrease, can you understand? If the denominator decreases, what will happen? Your pressure will increase, isn't it? So this is like simple math, right? So if this is 1 over V, if this becomes less, then obviously a lower denominator is going to divide this 1, so your pressure will increase. So when this decreases, pressure increases. So there's inverse relationship between them, and this is known as Boyle's law. And if your volume increases, your pressure decreases. And this is, we're talking about volume of a gas. So here let's look at how this Boyle's law works.
In order to understand the mechanisms of breathing, it's important to understand the relationship between pressure and volume. This is explained through Boyle's law, which states that the pressure of a gas in a closed container is inversely proportional to the volume of the container. What do we mean by this? If the size of the closed container is decreased, the pressure of the gas inside the container increases, and that if the size of the container increases, the pressure of the gas inside the container decreases. Imagine a gas, shown here as blue molecules, inside a cylinder with a movable piston and a pressure gauge. If the piston is pushed down, the available space inside the cylinder is reduced, which compresses the gas. This means that the same number of gas molecules have less space to move around in, with the effect that they strike the walls of the cylinder with more frequency. If you observe the pressure gauge, you'll see that the pressure doubles as the volume is reduced to half. Conversely, if the piston is pulled up, the available space inside the cylinder is increased. This means that the gas molecules have more space to move around in, with the effect that they strike the walls of the cylinder with less frequency. In this case, as the volume doubles, the pressure is reduced to half. And it's these differences in pressure caused by changes in lung volume that allow us to breathe.
So having understood that, okay, so now let's look at what happens in pulmonary ventilation. So we are looking at inspiration first. So let's see this first one where there is increase in vertical diameter. So this first one in vertical diameter. So the diaphragm is the one which increases the vertical diameter. So the diaphragm increases the vertical diameter. So what happens is that when the diaphragm contracts, so here you can see this diaphragm here, it's dome shaped, right? So when it contracts, it actually flattens out. So the diaphragm becomes lower. It comes down here somewhere. So let's say it comes down here. So when it comes lower down, can you understand now the volume of the thoracic cage in the vertical diameter would have increased, right? So the diaphragm descends and comes lower down. So the volume increases in the vertical diameter. Let's look at the next part, which is in the transverse and anteroposterior, that means going from front to back. So first let's understand transverse diameter. And if you look at this image, you can see that these ribs are present in an oblique fashion. So can you notice the ribs are present obliquely? So the muscles used here are the external intercostal muscles. So they are these muscles, the external intercostal muscles. So when they contract, what they do is they pull the lower rib up. So from an oblique position, this lower rib actually now becomes more horizontal. It'll come up and become more horizontal. And this is often, the example is given, it's very similar to a bucket handle. So imagine if you look at a bucket like this, and you have the handle of the bucket lying on the side this way. Okay, can you understand that the handle of the bucket's lying on the side this way? Okay, you following what I'm drawing? So this is the radius, okay, this way. So it's an oblique, it's placed obliquely, lying by the side. Now if I lift the handle up, it's going to be this way. Can you understand? So now can you see how the radius and hence the diameter, because we use on both sides, how it would have increased? And that's what is being shown over here. So from this oblique position, when they become horizontal, the diameter increases in a transverse fashion. So this external intercostal increases the transverse diameter. At the same time, how does it increase the anteroposterior diameter? You see, what happens is that the ribs in ANP1, you should have done this, the ribs increase in length from above downwards. And, around about the 8th or 9th ribs, those are the longest ribs. So can you understand when this, say the 8th rib is going to move up and become horizontal. So from this oblique position, it's going to move up and become horizontal. The 7th is going to move up and become horizontal. So they are going to move up into the space of the rib above them, right? But ribs increase in length from above downwards. So in other words, say the 8th rib is longer than the 7th. 7th is longer than the 6th. 6th is longer than the 5th. So 8th is going to go into the place of 7th. 7th is going to go into the place of 6th, and so on. Now, if a longer rib is going to go into the place of vacated by a shorter rib, how is it going to accommodate itself? Do you see how these ribs are attached to the sternum over here? These first 7 are called true ribs, right? So what they do is when they are attached to the sternum, they actually move the sternum forwards like this. So if you look at it from the side, so imagine this is the vertebral column and this is the sternum up here in front. So these were the ribs in an oblique fashion. Now they become horizontal like this. So what they do is they push the sternum forward this way. And when they push the sternum forward, now a long rib can occupy the space vacated by a shorter rib. So what happens? The anteroposterior diameter also increases, okay? So this increase in transverse and AP diameter, both transverse and AP, is done by the external intercostal muscles. So here, can you see, you have increased the transverse diameter, you have increased the anteroposterior diameter, and you have increased the vertical diameter. The whole volume of the thoracic cage has increased because of the attachment of the visceral or the gliding of the visceral and parietal pleura. When the volume of the thoracic cage increases, automatically it pulls on the visceral pleura and the lungs. So the lung volume also increases. So when volume increases, what happens? Pressure goes down, remember? Okay, so the volume increases. So the pressure inside the lungs decreases. So it's less than the atmospheric pressure. So therefore, air will begin to move into the trachea and into the lungs. So air moves in. Followed? Okay. So here, let's look at that.
The mechanics of breathing involve changing the volume and pressure of the thoracic cavity. By using the principles of Boyle's law, one can see that the pressure in the thoracic cavity is inversely proportional to its volume. When the intercostal muscles contract, the ribs are elevated. At the same time, the diaphragm contracts. These events expand the thoracic cavity, decreasing its internal pressure. The lungs expand, filling the thoracic cavity. The resulting pressure in the lungs is lower than that outside the body. Air enters the lungs until equilibrium is reached. When the diaphragm and the intercostal muscles relax, the thoracic cavity recoils. The resulting increase in pressure causes the air within the lungs to be expelled.
So this shows you how expiration also occurs. So you saw that volume increases, pressure decreases, air moves in. So this was active because these muscles were contracting actively. So let's answer this question before we go on to expiration. Yes, very good. The volume has increased and pressure has decreased. Now, Which muscles increase the transverse diameter of the thorax during inspiration? Excellent. External intercostal. And which ones would increase the vertical diameter? Diaphragm, yes. So now expiration. Now this is a passive process. Except when you forcibly want to expire air. Like for example, you're blowing a balloon or you're blowing forcibly into something. But otherwise, when you're doing normal breathing, expiration is passive. And it is because the diaphragm relaxes. So it comes back up to its normal position. The intercostal muscles, external intercostals also relax. So the the ribs from a horizontal position become oblique again. So what happens is that the volume inside the thoracic cage now decreases. So the volume decreases because in the thoracic cage, if from this position now the diaphragm has gone up to this, back to its normal position, these transverse and AP diameters have decreased, so the volume decreases and pressure increases. So it is more than the pressure outside, more than the atmospheric pressure. So air begins to move out till it reaches the atmospheric pressure and there's no gradient there. Okay? Some important things to remember. I said the diaphragm or the external intercostal muscles can each at rest actually take over inspiration. So we need to know the nerve supply. The diaphragm is supplied by the phrenic nerve, which comes from the cervical segments of the spinal cord. So if this is the spinal cord up here in the cervical segments, cervical 3, 4 and 5, that supplies the diaphragm. So these form the phrenic nerve which goes to supply the diaphragm. From the thoracic segments, from thoracic 1 to 12, these segments, they supply the intercostal muscles. Okay? So if the phrenic nerve, if you cut the nerve up here, the intercostals could sort of take over. Or let's say, it's very difficult to cut each one of the intercostal nerves individually because there are 12 separate nerves. But let's say your spinal cord is, for some reason, there is a damage to the spinal cord at this level. You can understand the phrenic would still be present, so the diaphragm could take over. But if you transect the spinal cord up here, that means you cut the spinal cord at the level of just above C3, then this is followed by death. It becomes fatal unless, you put the patient on a respirator. So let's look at expiration. So here, the diaphragm inspiratory muscles relax, so it's passive, like I said. So the diaphragm goes back to its normal position. The intercostals again go back to the normal position. The vertical, the transverse and anteroposterior diameters decrease. So the thoracic volume decreases. The intrapulmonary pressure increases. So then air flows out till no gradient is left. So till it reaches atmospheric pressure. And, then it stops and then you begin the next cycle of breathing. Now in forced expiration, when you're forcibly trying to push air out of your lungs, like blowing into a balloon or something like that, then that's where some muscles come into play. The most important of those are the oblique and rectus abdominis muscles in the abdominal wall, so the abdominal muscles, and the internal intercostal. Okay? So internal intercostal is an expiratory muscle, but only comes into play during forced expiration. So why do you think that if you transect the spinal cord above C3, that could be fatal? Yes, excellent, because both are paralyzed, and that's why I drew this diagram for you up here. So imagine if you cut it here, then this is above C3. So there'll be no impulses coming from the brain down to any of these, because from here it's cut, transected meaning cut. So the phrenic will not get any impulses, neither will the intercostals. However, if you were to cut it at this level where the phrenic nerve is spared, but the intercostal nerves are paralyzed. Everything below this will be paralyzed, but the diaphragm is still working, so it can take over. Okay. Now let's look at the factors which affect ventilation. Everything has to be normal in order for your ventilation to proceed properly. So let's look at the first one. The first thing is that of course, your pharynx and everything has to be normal. There should be no problems over there. Your adenoids shouldn't be enlarged and, all of that. And then let's look at the narrowest part of the larynx, which is the glottis. So here again, the glottic abductors, which remember there was only one abductor, which was the abduction was done by the posterior cricoarytenoid muscle. So that has to work properly so that it can abduct the vocal cord so that air can move through the larynx into the vocal cord. And in anesthetized patients, that's what you're worried about, and that's why you always have to put a laryngeal tube inside to help them, assist them with respiration. Then once air moves from there, it goes into the trachea. The trachea is large. It goes into the primary bronchi. They are also large. So usually don't expect any trouble unless, of course, there's a tumor or something inside. Then you finally come into the bronchioles, where remember the bronchioles were anything 1 millimeter or less, you call them bronchioles. Bronchioles have a slight tone, so you have to make sure that the bronchioles are dilated so that they can allow the air to go in. Because if the bronchioles were constricted, then air would not be able to flow, would not be able to pass. So and it stands to reason that during inspiration you have bronchodilation, so that it dilates, so it allows air to go in. And during expiration there's a slight amount of bronchoconstriction so that it can squeeze the air out. So imagine if you look at it this way, during inspiration when air has to go in, the bronchioles will dilate so that air can go in. And during expiration when air has to go out, so these bronchioles will sort of constrict, squeeze a little bit so that they can push the air out. Okay, so that's normal. You have certain conditions certain diseases where you have problems. Some diseases are known as restrictive lung diseases, where which many people who are in the mining industry, they tend to have asbestos, coal mining, and so on. What happens is that these little fine granules, when they go mining coal and asbestos, they go and settle down in the elastic tissue of the lungs. And when they go and settle down, they don't allow the alveoli to expand properly. So can you see that it can be a little restrictive, this kind of a disease? It doesn't allow the alveoli to expand. This can also be true in case of the chest wall. Imagine if the thoracic cage was not properly formed, because remember, first the thoracic cage has to expand in order for the lungs to expand. So if somebody's thoracic cage was not formed properly, that also could be restricted. Then you have certain diseases which are obstructive lung diseases. So imagine if you had a tumor inside, that would prevent the bronchioles from dilating. Or you have diseases like emphysema and asthma and chronic bronchitis, where these bronchioles, they constrict even during inspiration and expiration. So again, they don't allow air to pass in. So again, that could be a problem. So these people have what is called airway resistance. So breathing becomes a problem. So it does affect ventilation, and it's not conducive to good ventilation. So let's say that your glottis is okay, their airway resistance is normal. I mean, you don't have too much airway resistance. Then you have to come into the lungs, and the lungs have to also stretch in order to receive this air. And here is what is known as compliance. Compliance means the stretchability, how much it can give so that it can take in all the air that needs to come in and then recoil to push out all the air. So that's known as lung compliance. And the chest wall also has to be compliant. In other words, the chest wall also has to expand. I gave you an example, like if someone's chest wall was deformed, then can you imagine that it will not expand properly? So then again, the compliance of the chest wall is not proper. And for lung compliance to be normal, one is the lungs have to be elastic, the thoracic cage has to be normal, plus the surface tension has to be lowered by surfactant. So if any of these three are not functioning, you can understand that lung compliance will not be good. So, for example, if the chest wall has deposits, if the chest wall is not formed properly, there are some bony deformities, or in the elastic tissue of the lungs, if you have deposition of, like I said, dust and soot and coal and asbestos and things like that. If you have fibrosis or it's surface tension in children, I told you that if a child is premature and not producing surfactant, the surface tension is very high, and then they have infant respiratory distress syndrome, and that's why they're distressed. They can't breathe properly, right? So let's look at some cases of airway resistance, and then we look at lung compliance.
We are not cut from the same cloth. We each have our own style, personality, and character. America from the condition known as asthma.
Asthma is a chronic respiratory condition in which a person's airways become narrow, making it difficult to breathe. There is currently no cure for this disease. Asthma is typically characterized by coughing, wheezing, and shortness of breath. When allergens or environmental factors cause a spike in these symptoms, it is known as an asthma attack. During an asthma attack, bronchi react to a trigger like an allergen with contracting spasms. The bronchi inflame and produce mucus, further narrowing the airways and leading to the symptoms of asthma. Attacks may last just a few minutes or can linger over several days. Symptoms can usually be relieved using asthma medications, but may also disappear naturally in mild attacks.
So that's why whenever you always give the drug, like a sympathetic drug becomes dilates the bronchi. Parasympathetic narrows them. So you want to give them a drug which acts like the sympathetic nervous system. So something like epinephrine, which will dilate the bronchi. And let's look at lung compliance.
Have you ever taken the time to think about how vital your lungs play a role in helping you perform daily tasks? I'm Lena, a respiratory student at Pickens College in Colorado. Since becoming a respiratory student, I've become more aware of my breathing. In this video, I would like to explain what compliance is. Compliance is the ability of your lungs and chest to expand, or how well your lungs inflate. It is defined as the change in volume over the change in pressure. In a stiff lung, there is less compliance due to the lungs not being able to expand in its full capacity. Let's relate this to a disease. Mesothelioma, lung cancer caused by exposure to asbestos. Asbestos fibers are lodged in the alveoli and create scar tissue. Over time, scar tissue spreads throughout the lungs, causing stiffness. As you can see, there is a decrease in compliance in the diseased lung because it is not able to expand easily. According to asbestos.com, about 2,000 to 3,000 new cases of mesothelioma are reported each year in the U.S. My grandmother was diagnosed 2 years ago, and because of the decrease in compliance, her breathing has become more difficult. Compliance. Now that you know what it is, how does it affect your daily life?
Okay, let's answer this question. A person has severe scoliosis. So do you think this will affect chest wall compliance? Yes, excellent. Because remember, the chest wall, if someone has scoliosis and this is how their vertebral column is, which is, curved like this. Can you understand on one side the chest wall will be kind of narrow this way, on the other side it's going to be wide, so these ribs will not be able to move properly, so the diameters will not increase properly, so their chest wall compliance will be. So it's not, when you say thoracic cage abnormality, it does not necessarily mean only ribs. It could be the vertebral column, it could be sternum, anything that makes up the thoracic cage could affect chest wall compliance. So why do you think coal miners are likely to suffer from severe respiratory problems? Yes, very good, because the coal dust or even as asbestos, as she said, it goes and settles in the interalveolar septa and reduces the elasticity. Let's look at some lung volumes now. So the first one is tidal volume, which is the normal amount of air that you breathe in and out during quiet respiration, usually taken to be about 500 ml. Then we have something known as inspiratory reserve volume. As the name suggests, inspiratory meaning what you can inspire, reserve, it's in reserve, that means you don't use it all the time, but you can use it. So this is it's about 2100 to 3200 ml. You don't have to remember the figures as much, but you can see this inspiratory reserve volume is the amount of air that you can breathe in after you breathe in your tidal volume, because that's what is held in reserve. So imagine like you were breathing normally and I told you now take a deep breath. So when you breathe normally and then you take a deep breath like that, the breath after the initial tidal volume is what is inspiratory reserve volume. Expiratory reserve volume. This is, remember, tidal volume is the normal amount of air that you breathe in or breathe out. So again, expiratory, that means what you can expire, but it's held in reserve. You're not doing it all the time. So expiratory reserve volume is the amount of air that you can breathe out after the tidal volume. So again, this is something like if I told you to blow into a balloon and just make it big. So when you just blow out normally, you're blowing out your tidal volume, and then you continue to blow out and make it, the balloon gets bigger and bigger. That is expiratory reserve volume. Now look at these two situations. Inspiratory reserve volume, whenever you have restrictive pulmonary disease like, coal miner's disease or asbestosis, because the lungs cannot expand, your capacity is not much. So you can't take in too much air. So it's greatly reduced. And expiratory reserve volume, when you want to breathe out, like blow out into a balloon and make it really larger, this is decreased greatly in something known as COPD, stands for chronic obstructive pulmonary disease, and the two common ones are emphysema and chronic bronchitis, which comes under this. So here, because then the emphysema, the alveolar walls actually, in emphysema is a condition, if these are the alveoli, the alveolar walls are damaged. So instead of having air sacs like this, you have one big huge sac whose elasticity obviously is not too much. And bronchitis is of course inflammation of the bronchi, so there's severe bronchoconstriction. So again, air can't be pushed out of the lungs, so these people have difficulty breathing in, but breathing out is even more difficult for them, okay? So their expiratory reserve volume decreases greatly. Then remember when we did the heart and we were talking about stroke volume, which is the amount of blood that's pushed out of the lungs, right? Out of the heart. So that stroke volume is the same as tidal volume. You remember there was always some amount of blood left behind in the heart, which we called end systolic volume, the amount of blood at the end of systole. Because the heart never completely empties itself out of all blood. Same way, in the lungs, you always have some air left behind. That air is known as residual volume. So the residual volume is the amount of air that's left behind in the lungs. It's taken to be about 1200 ml. It could be more than that when you're just doing a normal tidal volume. So then you can understand you haven't used up this expiratory reserve volume. So your residual volume will actually even include this expiratory reserve volume. So we call it what is known as functional residual volume. That means this is the amount that is left behind in your lungs, out of which you can remove this much. This will always be left behind in the lungs, okay? Vital capacity is where you add up these three. That means vital capacity is your tidal volume plus inspiratory reserve volume plus expiratory reserve volume. This is the total amount of exchangeable air that you have. This much air can be exchanged. Total lung capacity is all of this. So it's all of this plus residual volume. So it's this plus residual volume. So that's how you get, if you add up all these figures, you'll get 4,800 and you add 1,200 to it. That's how you get 6,000 ml. Now these are taken for an average individual, about 70 kilograms, a normal sized individual. If smaller people would have, the figures would be a little bit different. And then we have something which is known as anatomical dead space. So if you remember, we had something called the conducting zone and we had the respiratory zone, right? So if you look at the trachea and you go all the way from the trachea and you go all the way down and then you come up to the respiratory bronchioles and the alveoli. This is from here on is the respiratory zone and from here is the conducting zone. So dead space is the area where no gas exchange occurs. So you can understand that anything in the conducting zone would be part of dead space, right? The air has to remain in that area because it cannot be exchanged for gas, right? So that's called the dead space. And if in a normal, healthy human being, we say that's the anatomical dead space, you can't do anything about it. The air has to remain there. And usually we take it about 1 ml per pound of body weight. So if a person is about 150 pounds, right? The anatomical dead space, that means the amount of air in the conducting zone is 150 ml. So out of the tidal volume of 500 ml, so out of 500 ml, we take away 150 ml which is in the dead space. So only 350 ml is the amount which is actually exchanged. Do you understand? And there's nothing we can do about it. So we call this the anatomical dead space. And you can always calculate in a healthy human being, you can always say, if I tell you a person's weight is, and it's per pound, so if I say a person weighs 100 pounds, their anatomical dead space would be 100 ml, right? 150 pounds, 150 ml. This anatomical dead space actually can increase if there is any area of the lung where there's no gas exchange which is occurring, then that becomes part of your dead space, isn't it? So then it can increase. So then we call it, that's the physiological dead space, okay? So this is a good kind of a graph to show you the lung volumes. So this here, if you look at this is the normal tidal volume. So this here is the normal tidal volume, whatever you're inspiring or expiring, that's about 500 ml. And let's say you've inspired and then you take a deep breath in. So this is your reserve that you can inspire even more. So that's why it's called inspiratory reserve volume. So you understand your inspiratory capacity would be your normal tidal volume plus inspiratory reserve volume, because this is what you normally do. This is what you can do over and above the tidal volume. So that's why this part is called the inspiratory capacity. Then look at this. This is your normal expiratory tidal volume which you expire. And let's say you take a deep breath and you expire even more air. So this part here is known as expiratory reserve volume. That is what is left in your lungs. You can expire this much also. And then this is the amount that is left behind in the lungs if you take out the expiratory reserve volume, which is called residual volume. And remember, I said that normally you have something which is called functional residual capacity. Let's say you are breathing in and out normally. You're only pushing out tidal volume. This is the amount of air that is left behind in the lungs. So that's why it's called functional residual capacity. When you move this out, because this can be pushed out, this is what will always remain inside the lung. So this is the actual residual. This is the functional residual capacity. Since this always remains in the lungs, this is the amount which can be exchanged, the amount of air. So that's what is called vital capacity, or what is known as the total exchangeable air. And then your total lung capacity obviously includes all of these 4 volumes, right? Got that? Now, are bronchioles part of dead space? Yes, they are. Remember bronchioles. I said conducting zone. Dead space by definition is where no gas exchange occurs. Conducting zone by definition is where no gas exchange occurs, right? Conducting zone and dead space, no gas exchange. And remember, bronchioles are part of the conducting zone. It's from the respiratory bronchiole. I didn't use the word respiratory. It's from the respiratory bronchiole that you have the respiratory zone. So a normal bronchiole is part of the dead space because it's part of the conducting zone. So look at this. Todd has a tumor in one of his right secondary bronchi. This has led to collapse of the middle lobe. Do you think what will be the result on the dead space? Very good. It will increase because now that area is collapsed. So there is no gas exchange. So obviously his dead space increases. And this is what we say, this would be in addition to the anatomical dead space. Now you have this additional, this part here, you have this physiological dead space. Okay, this addition. So if I gave you something like a person's weight is 150 pounds, but the dead space is 200 pounds. Then you have to think there must be something wrong with the respiratory zone. So, maybe some alveoli have collapsed or some respiratory bronchioles are not functioning, which is why, because dead space by definition was 1 ml per pound. But he was only 150 pounds, but his dead space was 200. So that extra 50 was added on because part of the respiratory zone was diseased. Here, let's look at the next part of when we were looking at the whole process physiology of respiration was gas exchange. So there are few properties of gases which you should be familiar with. One is partial pressure of a gas. Gases are measured, you always look at the pressure of a gas in millimeters of mercury. Partial pressure is directly proportional to the percentage of gas in a mixture. If you look at the atmospheric air, we have oxygen, we have carbon dioxide, and we have nitrogen. Nitrogen is the maximum amount in the atmosphere. Carbon dioxide is the least. Okay. So if we say the atmospheric pressure is 760 millimeters, this is actually made up of the pressure of oxygen, the pressure of carbon dioxide, and the pressure of nitrogen. So these three together give rise to the atmospheric pressure. So since each is a part of this, we call it partial pressure of oxygen, partial pressure of carbon dioxide, and partial pressure of nitrogen. Have you followed? Okay. It's something like, imagine if I said I have a bag and the weight of the bag was, I say 10 pounds. But in this bag, I have 5 oranges. I have 3 bananas, and I have a few grapes. Get it? Right? So this 10 pounds is actually equal to the weight of the orange plus the weight of the bananas plus the weight of the grapes. Right? Individual weight of each of these will depend on how much of it is there. Same way here, which means the same thing. That means the more gas there is in a mixture, the more will be its partial pressure. Follow that? So that's one important thing to remember. So in this mixture of oxygen, nitrogen, and carbon dioxide, since nitrogen was the maximum, the partial pressure of nitrogen in atmospheric air will be the most, isn't it? Because it was the maximum amount of the gas in atmospheric pressure. Second is gases dissolve in a liquid. Gas can, you've heard of liquid nitrogen, liquid carbon dioxide, right? So gases can go from a gaseous state and they can go into the liquid state, and it depends on their partial pressure. And so if in a gaseous state the partial pressure is more, and in a liquid state the partial pressure is less. Remember, by diffusion always goes from an area of higher to lower concentration. So this will go from a gaseous into a liquid state. Followed? So gases can dissolve in the liquid. But this dissolving in the liquid also depends on how soluble that gas is in a liquid. For example, carbon dioxide is, of the three, oxygen, nitrogen, and carbon dioxide is the most soluble in a liquid. nitrogen is the least. So even though nitrogen pressure may be more, but it's not very soluble in a liquid, so it takes a long time to dissolve and go into a liquid form. Have you followed? Okay, so while it is dependent on the partial pressure, it is also dependent on how soluble a gas would be in a liquid, and the temperature also determines the amount of gas that will dissolve in the liquid. Okay, so temperature kind of makes it go from a liquid into a gaseous state. Now, gas exchange depends on these properties of gases. One is the solubility of gases and the partial pressure gradients. So if gases are more soluble in liquid and they can change from a liquid to a gaseous form or vice versa, that helps in gas exchange. And also partial pressure gradient. So wherever there is a gradient, so if there is more oxygen at one end and less oxygen at the other end, it will flow from an area of higher to an area of lower concentration. More carbon dioxide at one end, less at the other, it will flow in the opposite direction. And you'll see how this happens in the alveoli and in the tissues. So obviously, how soluble a gas is and what is the gradient. Next is what is called ventilation-perfusion ratio. So remember, we saw in the alveoli, when we looked at the alveoli, and when we were doing respiratory anatomy, you saw these alveoli, and remember you had blood vessels, which were these pulmonary capillaries, which were present all around. So ventilation is the amount of air which is present inside an alveolus. Perfusion is the amount of blood going to it. So perfusion is the blood supply. So the ratio between how much air there is in the alveoli and how good the blood supply is, that ratio has to be normal. Isn't it? You can't have a very narrow road and have too many cars going on that road. What will happen? You'll have a traffic jam. And there's no point having an extremely wide road and sending very few cars to that area. Right? Because you're wasting space. So the same thing is true for alveolus and the perfusion. So imagine if you have extremely well ventilated alveoli, that means extremely dilated alveoli, completely filling with air, but the blood supply to that area is poor. So can you see it's a wastage of the air there, and you'll see how the body will react to it. Or imagine if your alveoli are not well ventilated. Maybe some of the alveoli are collapsed and only a few are dilated. But you have a lot of blood vessels going to it, increased blood supply. So it's wasted because the gas exchange won't occur, right? So you'll see how the body reacts to it. So this ventilation-perfusion ratio has to be proper. That means well-ventilated areas have to have a good blood supply. Next is the respiratory membrane thickness. If you remember, we did the respiratory membrane. So it was the alveolus, the lining of the alveolus, the squamous epithelium, the lining of the capillary, which was the squamous endothelium here, and then the fused basement membranes. So that was the respiratory membrane. You wanted this membrane to be really thin so that gases could pass between the alveolus and the capillary well. Right? They could pass in easily. If this membrane becomes extremely thick, like it happens in, we just did coal miners' disease and, asbestosis, all that is deposited here. What will happen? That will make this respiratory membrane thick. Or, you remember I gave you an example of pulmonary congestion. When somebody has, let's say they have mitral valve stenosis and blood backs up into the lungs. So there's more blood in the capillaries that the fluid oozes out, so it kind of goes in this area. So again, it increases the respiratory membrane thickness. So gas exchange is not proper, so that's why these people feel a little breathless, right? So that respiratory membrane also should be thin and should not be thick. Then you have, finally, and this again is, if you look at all of these are common sense, your available surface area. The more the alveolar surface area, the better the exchange would be. If you have some alveoli which are not functioning compared in an unhealthy lung compared to someone who has a healthy lung, obviously the one who has a healthy lung with more alveoli functioning, the better the exchange would be. So the surface area is very important. So you don't want any part of the alveoli or respiratory bronchioles to be diseased. So let's look at this respiratory membrane thickness in gas exchange.
The process of exchanging gases between the atmosphere and the body's cells is called respiration and involves several events, including breathing. As we zoom into the body, we can observe the respiratory system during gas exchange. Air passes through the alveolar sacs to the alveoli, where gas exchange occurs. In this cutaway view of an alveolar sac and its capillary bed, the process of gas exchange is easily observed. During inspiration, atmosphere air fills the alveoli and gas exchange occurs between the alveolar and capillary epithelia. Oxygen in inspired air is represented as a white gas. Carbon dioxide in expired air is represented as a blue gas. Notice the change in color in the red blood cells during gas exchange. Now let's zoom into a higher magnification view of gas exchange at the respiratory membrane. Red blood cells in the capillary adjacent to the alveolus release carbon dioxide and bind oxygen.
So here you can see this is the alveolar squamous epithelium, the capillary squamous endothelium, and the fused basement membrane, and it's through this that the gases have to pass. Okay? So here is pulmonary gas exchange based on partial pressure and gas solubility. As you saw from that video, so when you breathe in, you have more oxygen inside the alveoli, and coming to the alveoli is from, remember, the pulmonary artery from the right ventricle, and this pulmonary artery is bringing deoxygenated blood, so it has more carbon dioxide. So there's more oxygen in the alveoli, which means that compared to this capillary here, so the partial pressure of oxygen is more in the alveoli. There's more carbon dioxide in the capillaries compared to the alveolus, so partial pressure of carbon dioxide is more. So what happens? Oxygen moves into the capillaries, carbon dioxide moves out from the capillaries into the alveolus. You breathe that out. You don't have to look at the figures, but this you understand. And now oxygen will go into the pulmonary veins, where it takes it to the left atrium, left ventricle, it goes into the aorta, and through its branches it's going into the tissues. Now at the tissue level, you can understand that oxygen is more in the capillaries, and so it's more than in the tissue, so oxygen diffuses out. So just the opposite from here. Oxygen diffuses out to the cells. What do the cells do? They are metabolizing. So they are, doing work. And when they do work, they produce carbon dioxide and water, right? So that carbon dioxide now goes back into the capillaries and it goes into the veins. So you have from the inferior, superior vena cava, and the coronary sinus, all of that then reaches the right atrium, and then the cycle starts again. Okay, so can you see? This is based on partial pressure. And it's also based on the fact that oxygen and carbon dioxide are soluble they have to go from over here from a gaseous form, because when you take in air, oxygen, it's in a gaseous state. It will get converted into a liquid state, and that's how it's going to be transported. Here, carbon dioxide will go in a liquid state, it will travel all the way, come here, and when it comes into the capillaries here, and it has to go into the alveolus, because you can't breathe out liquid, you have to breathe out gas. So from a liquid state, you understand it will change into a gaseous state and you breathe it out. Okay, so that's how you move from a liquid to a gaseous and gaseous to a liquid state. Okay, let's look at this.
Respiration serves as a means for the body to exchange gases with the atmosphere via the blood. The partial pressure of oxygen, PO2, in the air in the alveolar spaces in the lungs is greater than the PO2 in the blood, so oxygen diffuses into red blood cells from air in the lungs. Also, the partial pressure of carbon dioxide, PCO2, in the air in the lungs is less than the PCO2 in the blood. So carbon dioxide diffuses out from red blood cells and into the air in the lungs. Oxygen-rich blood is carried through pulmonary veins to the heart and then pumped through systemic arteries to the body. The PO2 in the blood is higher than the PO2 in the body tissues, so oxygen diffuses out from red blood cells at the body tissues. Also, the PCO2 in the blood is lower than the PCO2 in the body tissues, so carbon dioxide diffuses into red blood cells there. Oxygen-poor blood is carried through systemic veins back to the heart and is pumped through pulmonary arteries to the lungs, where gas exchange again replenishes the blood with oxygen and removes carbon dioxide.
Okay, so let's stop here.